So I'm going to give two stories first off, and these I think are very familiar to all of us. I'm a nurse, been a nurse for 35 years. I call you at 2 a.m., or I call one of your residents at 2 a.m. This patient's having what looks to be like seizures. The resident's response is, okay, load him up with the lamp. We will commit this patient to at least 6 months of therapy based on that information. They may not drive. In some countries, they may lose their livelihood based on the fact that we are treating that seizure activity as soon as possible. Here's another scenario I think is fairly common for those of us that work at university-type hospitals. Hi, my name's Dr. Smith. I work at the outlying hospital of East who knows where. We had a patient come in with seizure. We gave them Ativan. We loaded them with phosphenotoin. We gave them more Ativan. That wasn't enough. We gave them more Ativan. We intubated them. When we gave them more Ativan, we want to put them on a helicopter and fly them to your hospital, where you will monitor them for 48 hours. Notice that their blood alcohol level came down to 0 and discharge them. With that information, what I'm trying to do in my few minutes is convince you that I, as a nurse, can help you with these situations. And I think this is in the nursing domain. And so I'm going to present two quick scenarios. The first is non-convulsive, and this is a 53-year-old patient who arrived with a history of metastatic melanoma, left occipital lobe. Family observed some unusual activity. She had some twitching. Came into the emergency department. Nurses put Ceribell on. Nurses listened to Ceribell. Many of us nurses, we actually do listen. And we said, man, this sounds weird, because there's the two sounds. There's the and the and we figured the was bad. And based on that information, we called a neurologist who looked at all those squiggles and said, yup. And so they gave Ativan, and that ended up loading the patient with additional Ativan phos, and the patient was successfully treated in about 30 minutes. Here's another one, and probably a little bit more common. This is a younger female patient who arrives on her 5th visit to the ED with bilateral twitching followed by hyperventilation and drooling. And then this was observed in the ED, so Ceribell was placed, and it was not consistent with what we would think of as seizure. Instead of intubating the patient, sending them to the ICU, expending those efforts, this patient never saw the neuro-ICU. They were discharged home. So I think those 4 examples I gave you are kind of classic, and they break down pretty easy, right? In the first one, it was non-convulsive status epilepticus. We found it out in 30 minutes. How many of you would like to know what the EEG looked like before you gave the Ativan? We can whip one of these things around a headband, and nurses can do this. We're fast, right? We can apply this quickly, and I can be putting this headband on while one of my friends is running to the Pyxis, which nowadays takes like 8 hours to get a drug out, right? They're running to the Pyxis for the Ativan, and by the time we're giving that Ativan, we've got those first squiggles, which are retained, and you can see this stuff. In the second case, it took about 60 minutes to rule out, because it does tend to take a little bit longer to rule stuff out than rule stuff in, but we still have that data, right? So we can give you the information that you really wanted, so you know, like, what did Olson really treat, right? I may still end up giving the Ativan because I got to do that before you get there, right? But I can get all this stuff done long before the tech is even in their car. When I started nursing, nurses could not draw blood gases. We had stethoscopes. That became a big controversy a couple of years ago. We won't go down that road. We weren't allowed to run a code. Nurses can run codes. We can start IVs. We've learned how to read EKGs, these complex things that in 1983, my EKG class was 3 days long. Afterwards, I could say, PQRST. Right? Now we've trained, all of these are trends that if you look at how technology is evolving, this is nursing's domain. Okay? I'm not asking to read the EEG, but I'm telling you that if you embrace nursing, right, we can get this stuff on. We can get it in. You just gotta kind of get out of our way. Is what you really need. Just we'll do this, we'll get that information, and then you can make those big decisions. So I'm going to wrap this up really quickly in that I think that where the technology is going is that we at the bedside, this is going to be a nursing tool in my opinion. We should be available to make these decisions. You should allow us to, you should encourage us. We can get you more information, right? And we'll have those squiggles from which you can make the really complex decisions. And that's where I'll stop.